A very warm good morning to all. I, Aditi Sharma, fourth year BSc Nursing student from Asian Institute of Nursing Education, welcome you all to the second track of this annual Patient Safety Conference 2023 with the theme Engaging Patients and Families for Safer Care. Being a healthcare provider is a dynamic and challenging process, and the patient himself, along with his family members, occupy a central position whose active engagement, vivacious spirit, and comprehensive understanding of the ailment proves to be of immense value in the recovery process. To dwell more into this profound aspect of effective healthcare, we have today an outstanding panel, and this will be chaired by Madam Thangam Gomez, who has an exceptional multidimensional understanding of the subject. Madam Thankam Gomez is the founder member and the first president of ANEI. She is an entrepreneur and founder CEO of Signia Healthcare. Now, I request Madam Thankam Gomez to lead this erudite discussion with our esteemed panel members. Let us begin with our minds fresh, hearts warm, and may we all emerge with more insightful values. Thank you.
Thank you, Aditi. Thank you so much for that warm introduction. And so far, we had been running ahead of time. I just would like to take a few moments to share a video with all of you before we get into our panel discussion. It's very important to remember that how easily we can harm a patient, even if there are no intentions. I'm very sure that none of us, we come to hospital with the idea that I'm going to harm a patient today. I'm sure of that. So just if you give me one moment, I want to play one video before I invite my co-panelist, because I know that we are a little ahead of time. So I'm buying that time by playing this video just for all of you to view and reflect upon.
One night, I got a call from my mom saying, Dad, he has idiopathic pulmonary fibrosis. It was terminal. We knew that the average wait for lungs was 18 months. Unbelievably, he got the call, so they had the gift of these lungs, and they had to be used. It went really well. It was a 9-hour surgery, and he came through with flying colors. And his pulmonologist said, you're gonna be great to go. He needed to use the bathroom, and a nurse left him there because, as you can imagine, she had other patients who needed her too at the same time. And I fully understand why she made the decision that she did. Well, he got tired of waiting for her. He decided to get up, go back to bed on his own, and when he did, he took a fall and hit his head on the side of a bed. But they put him in horizontal traction. So he had to be perfectly flat with his head in a cuff to keep him still. A doctor did not show up until Sunday evening, a full 57 hours later. By then, pneumonia had set in, and he was in the ICU the next morning. I asked for a meeting. All of the doctors lined up in Dad's ICU room at this point, and there must have been about 6 or 7 of them, all in their white coats. How can we work together? How can we collaborate? Let us know. Tell us what could we expect? And they all, I'll never forget this, they stood there with their arms crossed, a solid row of white coats on one side, Mom, Dad, and me, trying to talk to them across Dad's hospital bed. And they basically said, nothing. There's nothing. And at that point, they could have said, we'll do whatever it takes to help prevent an infection, because that's going to be mission 1. We're not going to let your dad get an infection. After the ICU stay, he recovered from pneumonia, but then he was diagnosed with MRSA. He recovered from that and then came down with C. diff. And so it went another round of MRSA, another round of C. diff, and he eventually succumbed. I had to make our family's experience count for something. So I created the checklist that I feel that every single family needs to have to understand what to look for, what to say, and what to do to help prevent the most common preventable hospital hazards. There have to be cultures where it's okay to share information with patients and families, to show where there are potential cracks in care. I have developed curriculum and nursing workshops, and so I am in hospitals giving these workshops, and we work with frontline nurses and with nurse leaders. True partnership will yield better outcomes for patients.
So friends, I think there cannot be anything better than, having a video like this, played just before this panel discussion, which is on engaging patients and families for safer care. We will not find that many stories in India to discuss, but I'm sure that soon we will get to hear. This is not to blame anyone. It is more for all of us to reflect on that how can we be safer with these fragile lives who come under our care. So that's our responsibility to learn from others. And I am very proud that, we are associated with the Patient Safety Movement Foundation. And very quickly, we are going to sign the MOU for Patient Safety India. So these are all great, initiations for safer care for our patients in India. And we are the frontliners, especially the nurses. I always say nurses are the first and the last defense. And we take that role very seriously. That's why Association of Nurse Executives India, we spend considerable amount of time on activities around patient safety. With that, let me, introduce my co-panelist. And, as I call out, I will ask my panelists to come on, the video so we can all have the next track on discussing about engaging patients for patient safety. So just give me a moment. So we have Dr. Reshu Gupta Khanikar, ma'am, a very, very warm welcome. She's a senior consultant and HOD, Critical Care Medicine, Health City Hospital, Guwahati. And she's a teacher of multiple, programs. She's an examiner. She's a certified FCCS instructor. So the list goes on. And she's an active member of Indian Society of Critical Care Medicine. And she's secretary to different organizations. She's, of course, BLS, ACLS certified instructor. Ma'am, I'm a critical care nurse, so I am always in love with intensivists. So I'm very, very happy to welcome you to this panel, and warm welcome, and let's have a great time. And next we have Dr. Ashish Malakar, Group CEO of GNRC Hospitals, Assam, West Bengal. He's a strong visionary and he spearheaded sustainable growth in various dynamic environments. And I think he calls himself a catalyst with a lot of actionable solutions. And that's what I'm going to ask him, because he's at the helm of affairs in the healthcare delivery system. So that's what we are going to discuss with him. And then, he is also instrumental in establishing BSc nursing colleges in North India, one in Guwahati and one in Agartala. So I think he knows nurses also very well, because he initiated the nursing colleges. Sir, Dr. Ashish, a very, very warm welcome to this panel. And we look forward to, having a great time. 1 second. Sorry about that. My mouse sometimes is really playing around. That's the problem. So next on panel, we have Mr. Sanjeev Kakati, Director, Management Services, Third Eye Education Private Limited. Mr. Sanjeev, can you come on the video, please? And he's a graduate of electrical engineering, postgraduate in industrial engineering. Now, we might be wondering that how come we have an engineer on our panel? That's with good reason that we have an engineer of over 33 years, because he spent his life in quality, productivity, environmental safety factors, and occupational health management, system design, process improvement. That is pretty much, high level work in quality and safety. And it is always good to hear from a person who is not within the healthcare delivery system. Sometimes what is happening very close to our eyes, we cannot see. In leadership, there is a saying that if you want to know what is the problem, get on the balcony. That means that, don't stay within the problem, just get up, get on the balcony, view the things that is happening, then you might be able to see what exactly is the problem, and we might be able to have a solution. So I'm looking forward to have a great discussion with Mr. Sanjeev as well. A very warm welcome, Mr. Sanjeev Kakati, to the panel. Thank you for being here. Next, we have Madam. I'm really sorry about my mouse. We have Ms. Urmila Barua, the managing partner of Human Network. And now this is a very, very important member of this panel. That is, Madam, I know that whatever is written on the screen, she's a HR consultant into capability building, training, development, HR solutions, visiting faculty at the Department of Business Administration. She's got a lot of laurels behind her, best young manager. But today she's not doing any of those caps here. She's here to talk about from the perspective of a patient and a patient attendant. And she has enough and more experience behind her to talk about. So that we will come to know as we get into the panel discussion. So thank you, ma'am, for being here. We are very excited that we are able to have a patient in our panel. And that is a first for our, any panel. So I hope this is not the last. We are going to have a lot of engagement with patients and their families. Oh, I'm really sorry about that. Just give me 1 second. My mouse is giving me a little trouble. Just give me a moment. Yeah. I'm so sorry, Minnie, that I took a couple of seconds to come to your, slide. We have Miss Minnie Varghese. She's a member of Annie, and she's also the CNO of Fortis Hospital, Mulund. And we will hear from her the nursing administrator perspective. And I really look forward that we will have an energetic discussion from various perspectives. And last but not the least on our panel is Ms. Karishma Kaunt, member of Annie, and she's from Apollo Hospital, Guwahati. She is somewhere very young. She's also an leader, and she has just grown from being a bedside nurse to the leadership position, and now she's there. So she's going to talk from the perspective of a staff nurse. And with that, let me welcome all of you. And we have all the panels on the screen. I'm also watching what the attendees are watching. So they are seeing all of us, and a very, very warm welcome to all of us. And before we get into the real discussion, I have a couple of minutes extra. So I'm going to ask each one of you just to say one line about how you feel being here. So I'm going to start with Dr. Reshu. Then I will come back to the question to all of you in a while. Just one sentence, how you feel being on the panel today in Annie's third, patient safety conference.
It's an honor, ma'am, to be here. And the theme of your conference today is very dear to my heart. I would just like to say, in my ICU, this is one thing we actually wholeheartedly we do and we follow, that regarding that communication and the patient safety throughout the stay of the patient in the ICU. So I won't take much moment. I think there are many others to answer that. But one thing I would really like to share that I'm immensely happy that amongst the panelists, we have Mrs. Urmila Borua, because we as clinicians would definitely like to hear and listen more from her as a patient and patient attendance perspective. So thank you so much for having me here.
Thank you, Dr. Reshu. Let me move on to Dr. Ashish Malakar.
Yes, if you ask me, I would say it's a wonderful platform, and we can give something back to the society. The thing that plagues every family whenever they're in distress. So I think that is the outcome of this should be, we should be able to, give something back where people can, they can relate to, and they could learn something. And we also could be more aware of how can we give back the requisite amount of care that is expected from us.
Thank you, Dr. Malakar. Mr. Sanjeev Kakati, you're muted, sir. Meanwhile, let me move on to Madam Urmila Borua.
Yeah, good morning. I think I'm so impressed that, you have a panel like this, and among others, you have included a patient because, or a patient representative, because ultimately healthcare is about the patient. And I think that most of the time we as patients or patients attendant feel unheard. So I feel that this is a really good opportunity that you have given us to hear the patient's perspective as well. So thank you for having me on the panel. My pleasure.
Thank you, ma'am. Over to Minnie and Karishma. They are just from exactly where things can go wrong. So let me ask Minnie, what's her feelings being on this panel, and then move on to Karishma. We'll wait for Sir Sanjeev to join back. We have lost him. Yes.
So thank you so much, ma'am. And it's good morning to all. And it's a great privilege to be associated with Annie. And today this topic is very close to my heart. And as a nurse leader, I have a lot of examples to be given. And the topic is also something which we can talk a lot of practical points in this topic. And it's an honor where at present, I think 488 participants have logged in across India. And that is something great, and to share our knowledge. And thank you so much, Tanga ma'am, Ajita, and Annie, for giving me this opportunity. Thank you so much, ma'am.
Thank you, Minnie. Thank you. Mr. Sanjeev, is your audio okay now?
Yes. Am I audible? I
yes,
think.
yes.
Right.
You are.
Sorry for the snag.
No problem.
I look forward to today's event as a great learning opportunity for me. Till now, whatever we have heard, especially from Dr. Ramsey, in fact, that was the beginning point. And I expect there will be a lot of experience sharing, and we'll also learn about the future in patient safety. Definitely, we'll get a lot of ideas, and this is what we look forward for today's event. Thank you.
Thank you, Mr. Sanjeev. Karishma?
Thank you, ma'am. Namaste to everyone. Ma'am, I think we hear a patient every day, but many times we often listen instead of hearing them. But this is a panel which is happening, I think, for the first time, and it is only possible because of Association of Nurse Executive India, that where a patient's involvement is given importance, that while discussing about patient safety and what is we want to take them from their perspective, that how do they want us to engage them. So ma'am, this is a wonderful platform. We are looking forward. And I think patient involvement is the panel like this is exciting me more. And I believe the fellow, my young nurses, whoever is looking today and participating in this conference. That's all from my side, ma'am. Thank you.
Thank you. So once again, a very, very warm welcome. So the track is going to be an hour and 15 minutes. And I hope that we can handle 2 or 3 rounds of question. Let's see that. And I'm going to ask some very specific questions to each panel. And I have made the order in such a manner that, we get more out of what we are discussing. So first, my question is towards Dr. Reshu. So you are an intensivist. Many times in the ICU, we are busy working with very, very sick patients. And I used to say we are in the business of, healing in the ICU, because that's more important, that, we should be taking care and healing them. And sometimes engaging with with the patients themselves, if they are conscious, and with the family, even when they are unconscious, that can become a little bit of a far cry. And because we think, our job is to first save lives. That's most critical. So I keep wondering that, what would you think, because you're in the thick of things in the ICU, that why we should, take time to engage with patients and family while we are busy saving lives?
Yes, ma'am. I think this is a very, very relevant and very important question in today's panel and today's discussion. We need to communicate with the patients as well as patients' relatives regularly. It is very important. Just the clinical thing, like dealing with the critically ill patients, working on that, just that is not enough. Communication with the patients and the patient's relatives is of equal importance. We need to communicate them to prognosticate the patient. We need to communicate them to know about the expectations. What are they expecting from the patient? What are they expecting as from a clinician? What is their expectations of their family members? Again, this is very important to maintain the transparency of the treatment. Whatever we are doing, it has to be very transparent. And most important is it should not be just a one-way communication, and we should be there listening to the attendants as well as to the patients. Many a times we just ignore the patient's viewpoints. We think no, patient is having psychosis, or he's having dementia, or he's having irrelevant talk. But no, that is very, very important to be there. Trust me, when I enter my ICU, my first thing, before even I take the handovers, I just move around my ICU of 40 beds, and I just say a smile, a hello, a good morning to each and every patient of mine who is conscious. That itself makes boost their energy a lot. Also, as I said, the communication has to be two-way. It should not be just you telling them, but you also have to have that patience to answer or to listen to the patient's relatives, to the patients as well, and listen to what are their queries, what are their fears, or what do they understand of the whole clinical scenario that the patient is in the ICU and in what state they are. So, and this communication, it should not be robotic. It has to be more of human relation. There should be a proper counseling room. You sit with the attendants, you sit with the patient as well in the ICU and discuss and talk to them with more human touch in it, and not just being a doctor, clinician who is dealing with a very serious problem there. So this is what I would like to say. And also it avoids a lot of misunderstandings in the future go. And it has to be, as I've said, a continuous process, not one day communication, but it has to be an everyday communication. At least once in a day is important. Thank you. You are not audible, ma'am.
Sorry. I said I totally agree with you, Dr. Reshu, and I can imagine when you're in the ICU, why that two-way communication is very important. Many years ago, when I was in the ICU, I used to work with our nurses to speak to patients who are under sedation and who are actually unconscious. I said, just keep on talking to them. And I have had experience where the patient woke up from the unconscious state because the patient was involved in RTA. Finally, young patient, 18-year-old patient, he woke up and he recognized the voice of the nurse who spoke to him maximum, more than his family. When he woke up, I was in the Arabic speaking country. So the moment he walked in, I still remember the male nurse's name, Benjamin. When he walked in, he asked, Wallahi, Tal. He said, Ki, come here, come here. He said, I know you. Because he heard his voice. He used to give him, manicure and pedicure and all, and he will be continuously talking. I mean, that's an experience every nurse must have. There's nothing that I can give to anyone. This is something a nurse experiences when they are with the patient. So sometimes it is very important that we, all of us, know that hearing is the last faculty one can lose, when they are unconscious. So what we talk around them, how we talk around them becomes very crucial. So there is small things for everyone to take. You don't have to do very big things, out of this world. Maybe when I'm an ICU nurse, I must just start by speaking to my patients, understanding that they can hear. Believe me that they can hear. So that we don't use a language that he does not understand. I'm sure the doctors sometimes, very sensitive doctors, they will not talk the patient if he's deteriorating. So consultant will say, we'll talk outside. They don't talk in front of the patient, oh, he's getting worse, he's dipping and all these things, So these are little things. So communication, when you said 2 ways, I just remembered all these things, So I can go on and on. So I don't want to steal the thunder from Minnie at the moment. So she's also a critical care nurse, and now she is a nursing director. So now tell me that, I told a little bit of my experience. So why do you think that it is important that critical care nurses or nurses in general must engage with patients and families, because this year theme is that engage with them to improve the safety. Now, how do we understand this? How will you like to put it, Minnie?
So, ma'am, for me, what do you mean by patient engagement? You don't require, the nurse need to say, I am going to engage the patient. It is just involving the patient in their own care in order to ensure patient safety. So according to me, that is patient engagement. And it is a responsibility of a nurse to have patient engagement due to various reasons. If a nurse looking after a patient, so first important thing is we all talk about holistic care. Now, how do you give holistic care? When you give holistic care, the very important, the point is engage the patient so that their emotional, all the preferences, the nurse able to understand and to adjust the cultural, spiritual, psychological need of the patient. So nowadays we talk so much about it in the critical care setting. Then the second point is the nurse will be able to make a proper decision making. When you communicate to the patient, patient preferences. Example, a nurse going to collect the blood collection. So while talking, she may understand, oh, this patient has a AV fistula in the hand. So, you should not do venipuncture on that hand. So nurse will be able to make certain decision while engaging, while talking to the patient when she does certain procedure. Then, as I said, holistic care is very important, that emotional support, and especially very important in a critical care unit when the patients are there on BiPAP or ventilator, undergoing some major treatment. So giving emotional support while during the treatment, where with the nursing interaction, she can build up the emotional well-being of the patient. Then the fourth important point is, many times there are misunderstanding, miscommunication between the doctor, nurse. Doctor may say something and the nurse is in picture. So while communicating to the patient, all this misunderstanding, miscommunication can be avoided, thus preventing into the complications which can occur. And of course, when you communicate, you will come to know what are the how to pick up early detection of issues. Now, what example I want to give is, sometimes we do get patients. So in our setting, example, what I want to give is, we have a cardiac PICU where we get a lot of patients from interior Maharashtra where they have communication problems. See, they don't understand Hindi. English to dur ki baat hai, they understand only Marathi. For such patient, for this small, maybe 2-month-old child, 3-month-old child undergone surgery, when they go back, now care at home. So the nurse only will be able to understand, oh, she has language problem. So let me do a demonstration for this patient to how to do care of wound at home. So you will be able to pick up such things when you have a communication and you have proper discharge planning. There are so many points I want to explain, but I think time is limited. You can build trust, you can create educational opportunities for the patient while you engage with your patient. You can improve your quality of the organization. We talk about quality improvement projects. How quality improvement project, or how do you elevate quality of care in your own organization? It is what the patient tell us, okay, these are my issues, which the nurse daily pick up. That is picked up only when you communicate to the patient. So when do you do this? When you do bedside handover. We talk a lot on bedside handover, but I think still, which is, nurses feel that, अरे मैं कैसा bedside handover करेगा, patient will listen what I am saying. But during bedside handover, there is two-way communication happen. During medication administration, there is two-way communication. You tell the patient what are the medication we are going to give. Maybe the patient must have not revealed that patient is allergic to those medications. So these are the two-way communication happens when a nurse does procedure. So according to me, engagement is a key important thing in safety, patient safety, and the nurse doesn't require any specific time or date where for nursing engagement. You go to the patient, you do procedure, you talk to the patient, you talk to the relative, where the good connect between the nurse and the patient happens, and the nurse become advocate for the patient, and nurse become the connect between the doctor and the patient. So according to me, these are the things the nurses should do. And because across we say we all are NABH accredited hospital, patient has certain right. So what are some of the right? The right for information on plan of care, progress, patient complaints, and right to involved in care planning and delivery process. So who will be able to do that? As nurses, we are with the patient 24 hours near the bedside. So it is our responsibility to engage the patient and help the patient to come out of the disease problem which he or she is admitted in the hospital.
Thank you, Minnie. That's a very passionate answer. And when she was talking, I was going back to my days when I was the nursing head. When I used to tell my nurses, no, why don't you talk to your patients? So my usually standard answer is, ma'am, we are very busy. I said, you don't need extra time to talk to your patients. You are doing many procedures with the patient. Use that time to talk to them. Don't be keeping quiet, going inside the room, do your work and come out. It is very, very easy to, just dovetail your engagement, your talking into the activities that one is doing with the patient. It's very easily achievable. Why I'm saying this to all the audience, all the young nurses sitting there, I cannot tell you what satisfaction it gives you when you actually start speaking to patients and families like they are your own. That satisfaction, nobody can give it to you in a bottle or a spoon. That is something that you are going to experience. Once you experience, you get addicted to it. And I would say that I was addicted. And, I just could not do any duty without I speak to my patients. So I'm just sharing this experience. So Karishma, my question to you is that, do you think that our young nurses think of this as a priority? And how will you put it across to young nurses that, engaging with patients and families can actually be a tool to make the care more safer?
Thank you, ma'am, for the question. To answer this question, I feel honored and privileged actually to share this extreme esteemed panel with such a expert panelists across, and which is shared by you, madam. You act as a professional mom for all the nurses, young nurses like us. So to answer your question, ma'am, generally, all the nurses perceive positively actually about engaging the patient and family in different level of care. Theoretically, when we ask them, they all know that before every procedure, it is written in our books that explain the procedure to the patient and family. However, it has been seen that while practicing or dealing with patients everyday basis at bedside, the crucial link often get missed. And we find various factors involving in that. Like other day, like ma'am said, I'm too busy to not to talk, or I'm like that, I don't talk with people much. So these are the common statement we nurses give. And other day we found that some nurses say that I was with the other patient and I don't know when was the patient taken for CT, and finally the incident occurs that double time CT has been raised and it has been already done, where patient was not engaged, patient was not explained that, sir or ma'am, I'm taking you for the CT room for your investigations. Like many a time nurses say, I was explaining the discharge process. In that moment, one critical value I had to attend. So that process left unattended. It became incomplete. And many times nurses say that we are overoccupied with many non-nursing activities. I became busy, I don't get time. And they often ask, we also think, even this need to tell to the patients? Is it required to tell these patients? So many time as I start also, we hear, but we never listen. And language barrier, as Madam Mini has rightly said, it is a problem. And also not only knowing the language actually, but while talking with the patient, if we do not close the loop, again it is non-heard. As patient Urmila ma'am will definitely say, patient will feel that we are not heard. And not only verbal communication is important here, non-verbal communication also is important, where patients feel that even if I am talking with the staff, but I'm not getting that importance. And also, ma'am, a few things to say that nurses commonly get worried for the consequences of encouraging patient participation. They feel scared for sharing few confidential and sensitive informations. They also get fear of getting exposed if anything goes out of the way. They also get scared of few punitive actions which might take after such consequences happen. And I feel the art of engaging of patients, how to engage them, where to engage them, what all to talk with them, what is the importance that we need to focus that to the young nurses, so that they don't miss it and they understand the benefit out of it, that engaging patients will benefit both the way. It is a win-win game for nurses and as well as the patients. And nurses attitude matters a lot, because many nurse they are not like if I am talking about, if I have experience of experiencing an illness or within me or within my family itself, then I get the more importance that engaging is important. But a nurse who never experienced that, how to become a patient or how does we experience as a patient, then this different studies also says that those nurses get it less importance of engaging these patients. And I feel today's healthcare is moving faster like a bullet train, whereas we nurses are yet to catch the speed. To catch the speed, we need to build up our knowledge, to develop our confidence. If we are not confident enough, then engaging them in their talk, in today's treatment modalities, medication advancement, different procedure advancement, we feel that we are not equipped with all this. So we become less confidence. That's why we never talk with the patients. And many times, ma'am, new nurses says that we never practice this, we never get exposure in that, like these all things has to be taught with the patients. So this explaining to the procedures to the patient and family, although we talk, we write in our exams, however, it has to be ingrained into our daily practices. And
I have to hold on because
yes,
we are already
time is up,
the second part of my question. The barriers and solutions are also you're talking about. We'll come back to you in a moment.
Sure, ma'am. Sure. Thank you, ma'am.
Let me move on to Sir Sanjeev. Someone 2-3 days ago, a very senior person in healthcare, when I was talking about this conference, she warned me, Thankam, don't mix up quality and safety. Safety is different, quality is different. So that set my thought process. I said, how come that they are both different? So I would like to hear from you why these two things are different. Why is it important that we keep the safety, things separately and not at the same time as the quality? Would you like to shed some light on that, sir?
Yeah. First of all, I think this concept that safety and quality are different, that's not true. Let me come from the definition of quality. Now, there were the quality gurus like Juran, Deming, Feigenbaum, then Junichi Taguchi. They have defined quality from different perspectives. Now, if we talk about, say, Philip Crosby, he had said quality is conformance to requirements. Now, when I come to the healthcare, safety is one of the requirements. Without patient safety, we cannot think about the healthcare organizations or patient care or treatment. So that means quality cannot be different from safety. So this is one definition. So if I go to Feigenbaum's definition, he said quality is the degree to which a specific product conforms to a design or specification. Now, service is also a product. So it conforms to a design or specification. Now, when I'm designing a specification, or I'm designing something, or I'm giving a specification, that cannot be unsafe. So from that definition also, we cannot segregate safety from quality. This becomes a part. You come to Junichi Taguchi, he had said, any reduction in quality resulting from deviation of a characteristic or value, it commensurates to the loss of society. So there is a specification, there is a target that is as designed, and if you deviate from that, there is some loss, and it is he defined as a loss to the society. So whenever we are designing a healthcare service, then definitely patient safety has to be there, one of the parameters. You deviate from that, there is a loss to the society. I mean, a lot of medication errors or surgical accidents we see. Ultimately, this is a loss to the patient, and patient is a part of the society. He is a member of a family. So this is a loss. So from that definition also, we cannot say that quality and safety they are not the same. There cannot be any confusion on this between quality and safety. Now let us come to a universal definition, which is of quality, which is given by International Organization for Standardization, ISO. So there is a standard called ISO 9000. Latest revision was in 2015. That definition says quality is degree to which a set of inherent characteristics of an object fulfills requirement. So this is a very broad definition. It encompasses all the definitions given by the quality gurus. So object fulfills requirements. Now, what are those requirements? If we think about the in healthcare sector, the requirements are, or the meaning of requirement is need or expectations that is stated, generally implied, or obligatory. This is the meaning of requirement. Need or expectations that is stated, generally implied, or obligatory. Now, when you think from the patient's point of view, stated need is, of course, the pain they're undergoing or their ailments, etc. When they come for the treatment, it is implied that they will look for a safe treatment. No, they would like to go back safe. No, their expectation is that they will be cured. They don't expect that there will be further damage. So patient safety becomes a implied requirement. Then also it is obligatory. In many cases, certain accidents, for example, a patient falls and suppose the patient dies. It's a medical legal issue. Blood transfusion. There are certain surgical safety requirements. There are many obligatory issues. So again, from the ISO's definition also, we say that quality is, quality and safety, they are like two sides of the same coin. So we cannot say that there is a confusion between safety or quality, or they contradict each other. Again, I'll reiterate, that's the two sides of the same coin. When we talk about quality, we have to talk about safety, and when you talk about safety, we have to talk about quality. I think this I'd like to say.
Okay. Thank you, Mr. Sanjeev. I think you put it across very nicely. So even my answer to the senior leader was, I said, I thought for a moment, I said, yeah, obviously there is no quality if there is no safety, right? So that took me to my one of my statements when I was working in hospitals. I used to tell in probably senior management meetings also, we have fantastic infrastructure. When people come in, they say, wow, what a facility. Okay. Barring the bill that comes later. But before that, they meet the front office, they meet the security, they meet the nurses, they meet the doctors, they meet many people, right? In their journey of being a patient. In the entire journey, there is only one constant, that is the patient. Rest, all of them are changing, different people, they come and take care, and all of us are coming together. That itself is a big challenge for safety because too many people are involved in caring of that one patient. So that's a high risk factor. I'm very sure that Mr. Sanjeev, as person of quality and standards, will say that, this is very critical to have the teamwork, synergized well, focused towards the safe care of the patient. So if you ask any group of people at any point of time, that what will you rate first, safe care, not to get harmed, or it is the nice uniform, nice smelling doctors and nurses and, fantastic infrastructure, what do you want? First, they will say, send me home. Don't give me any additional harm. That is what they would say. So I am holding on to speaking to Madam Urmila the last. And before that, let me put Mr. Ashish, Dr. Ashish Malakar on the hot seat. I always like to call hot seat. It's because he's the CEO, the boss of everything. So there is a common perception that safety is the job of patient safety officer, chief, experience officer, ICN, quality, or the nursing department, or the medical superintendent, So while the CEO is quite busy with, P&Ls, profit and loss and, business advancement and all these things that the CEO, of course, you have to spend time in that because that's also important. But why do you think that top leadership must get involved in safety initiatives?
Thank you for raising this important point. However, I'd also like to get it clear that the CEO's activity encompasses a lot more and not just into P&L and business.
Okay.
And this is especially true in being the ultimate leader of an organization, wherein the onus categorically lies on setting the direction and vision and the culture of safety in an organization. I always believe that people who come to healthcare, be it doctors, be it the nurses, be it paramedics, anybody, in fact, non-medicals, even the GDAs, if you have come to healthcare, you must be a special soul. You don't have any job in healthcare if you do not have that empathy, that tender. It's just not that, just for the sake of earning your livelihood, you should get a job. If you're coming to healthcare, you must be above all these things. However, coming back, I'd like to also emphasize the CEO, in fact, establishes and maintains the values, mission, and goals, which in turn shape the overall tone and culture of the organization. This apart, a very crucial role CEOs perform is communicating the company's values and expectations to the employees and ensure its alignment. Also, a CEO's position entails leading by example. They must have significant impact on the organization's tone by demonstrating the desired behaviors themselves. To me, CEOs must act in line with the safety values proposed towards the patient and their families. It sets a possible, a benchmark rather, a positive example for all stakeholders to follow. Because you see, when you talk about organization is nothing but a culture. And culture pertains to human beings. It's not that, when you talk about, bringing safety initiatives, it is the culture that we human beings bring it. And having said so, It's also very true that the designated patient safety officers or the clinical nursing officers or the infection control nurses or even staff nurses or even quality, they play along the crucial role of ensuring safety within the hospital. But like I said before, setting the tone is the precursoral foundation towards establishing safety of patients and their families within an organization. When top leadership clearly communicates their commitment to the patient safety, it creates a culture where everyone understands that safety is indeed a priority. Very important when you talk about P&L, and I'd like to emphasize here, a very important aspect that comes to the fore is resource allocation. Yes, we're being responsible profit and loss and overall business strategy, but however, it is the patient safety and the quality of care that is integral to the success and vision. That is, if you talk even from business, that is the actual business, the safety and quality. By championing safety initiatives, CEOs ensure the appropriate resources, both financial and human, are allocated for this support and these efforts to be made. I'd like to also say that quality entails cost. When you talk about quality, you have to incur a cost. And this includes investing in HR. When you talk about even putting the IC and the ICO, even the quality personnel, it involves a cost investing from HR perspective. You need to invest in technology, training, infrastructure, staffing levels needed to maintain safe environment for patients and families. I'd also say that collaboration and accountability by engaging the safety initiatives allows top leadership to collaborate the frontline staff, the PSO, CNO, and other healthcare professionals. And by actively participating, organizations can gain a better understanding of the challenges that they face on a daily basis and work together to develop solutions. This collaborative approach, this brings in a sense of accountability and the organization where everyone understands the role of maintaining safety. I also like to emphasize on, not just the, putting people and resources into place, we need to have continuous improvement. Safety are not meant to be one-time endeavors. It requires ongoing commitment to continuously improve and monitor safety practices. When top leadership actively participates in these initiatives, I think it sends a very strong message that safety is not just a checkbox, activity, but a continuous goal. We need to also, by doing all these things, we are demonstrating a patient-centric approach. Also, this entails, engaging patients and their families in safety initiatives, and it can lead to better outcomes and overall patient satisfaction. And by involving top leadership in these initiatives, we show our dedication to the patient-centric approach, the mission and vision which the healthcare they talk about. Patients and families need to see that we prioritize that, their safety is above everything. We want them to go home safe. We just don't want them to stay here for long. We have a thing ticking behind your back that's called a loss. The average length of stay, that's something we also need to take care. So we just want them to go and safe and not to come back again to the hospital, So in conclusion, with the specific roles mentioned to play vital roles in ensuring safety, it is critical for CEOs to get involved in safety initiatives by setting the tone, allocating resources, collaborating with frontline staff, demonstrating a patient-centric approach. We can foster a culture of safety that benefits everyone involved. And remember, safety is everyone's responsibility, and CEO, it is our duty to lead the way. I'd like to sum up.
Thank you, Dr. Ashish. I think what you told is that the CEO's responsibility is to set the culture of safety. That reminds me of Amitabh Bachchan when he said that, I can walk English, I can drink English, I can talk English, I can dance English. So something like that. Utte jagte should be safety. So now there is a new word in US called high reliability organization. That means you can rely on these organizations to give you safe care, right? So I think to reach there, obviously in anything, whether it is reducing the pressure ulcer, whether it is zero pressure ulcer, or whether it is zero fall, when you look at any document, it talks about not the people who are in the front line. The diagram always shows the top management right on top, saying that, we endorse. And I think CEO, and you are also wearing the hat of a clinician, Dr. Ashish. One of the things that I would definitely like to put it across at this podium is also that when the CEO starts talking safety to the clinicians, other people will find it easy to have a dialogue with those doctors outside the CEO's office. Because this is something that I found it difficult to have conversation with clinicians, because they think their job is only to treat the patient. Safety is somebody else's job. Dr. Eshu is smiling. But when CEO also talks the same thing, it becomes easy for Mini, Karishma, and other people outside, even for patient, to talk to the clinician. The patients are also afraid sometimes to voice their concerns while they are in the hospital. I have heard this from patients or families. They tell directly. They tell ki nahi, during the hospital, I will not say or anything. Jaane ke baad bataunga. They are scared that we will do something wrong, right? With all that, it's my honor to invite Madam Urmila. You heard all the people talking about that they all want to invest in safety. Now, I would like to hear from you, that you as a patient and as a patient attendant, what are your take on this? What should we be doing? Or why we should be doing? Let's answer the why first. Then we can ask you that what would you like us to do also?
Yeah, sure. Thank you. See, one thing that we all should understand is the time when a person is a patient or one's loved one is in the hospital. That is the time when one is most vulnerable. So at this time of vulnerability, it becomes, people are scared, like you said, people are scared. They don't know what's happening to them. They don't know what's happening to their loved ones. They are not sure what the outcome is going to be, what's the prognosis. So at this time, I think engaging with the patient, engaging with the attendant, and giving them a kind of, to the extent possible, a frank discussion about what to expect, what is likely prognosis. When these things are discussed with the patient and the patient's attendants, it helps them also to take certain decisions. So, the healthcare professionals may think that, the decisions lie with the healthcare professionals, but no, to a large extent, the decisions also lie with the patient and their families. So one of the, leading complaints that a lot of patients have is that they put the patient in a ventilator, and we don't know, and they're just lingering on. And a lot of people, like including myself, I tell my family members that never put me in a ventilator. I mean, you don't have to fight for my life. If I'm going, let me go peacefully. So a lot of people have that kind of desire also. So involving them, engaging them, letting them understand that what is it that is, how they are, what they are doing, what are likely to be the fallout of this. Sometimes there may be some side effects of what they have done. So helping the patient and the patient's attendants understand these things becomes very important, because I think ultimately people should and do have a choice. So that choice should also be given to the patients. You're not.
I'm sorry.
not
I'm sorry. I said, are you finished? Are you done with?
Yeah.
Okay. So, Ma'am Urmila, I think you sound like any other patient or any other patient attendant. Recently also we had an event in the family where we had to decide for my uncle what should be done. So the family, of course, was not from healthcare. So they called me and they said, can you help? And they are in Kerala. So I had to talk to the neurosurgeon, and they were going to do a craniotomy where he has already got massive hemorrhage in the brainstem. So I know as a critical care nurse, there's very little that can be done, and the surgery will carry a huge risk. And he was already 74 years old. So the doctor told the family that you need to go undergo surgery, and this is the cost of the surgery. The cost was the secondary factor. So I talked to the doctor and I asked him very clearly, can you tell me what is the chances of him surviving this surgery first? He should first survive. So he said maybe 4 to 5%. So I said, if this is your father, would you like to operate? Tough question. So he took a couple of seconds silence. He said, no, ma'am. So I said, sir, then we are decided. We don't like to go for surgery. We would like him to be as comfortable as possible and, let him go. Now, we had a webinar some time ago by Dr. R.K. Mani. He is the leading authority on end-of-life care. And that webinar is available on our channel, on our YouTube channel and his YouTube channel. He talked about where the end-of-life care is now in India and what are all the things which are available. And that is one action item we are still waiting to, do that so that, we can educate more nurses and doctors around where is this now standing. I'm not very sure if everybody is aware. It is possible to have a advanced directive, though it is not called exactly that, but it is possible. The dialogue should happen. So that's a very important perspective that you have come across. So thank you so much for sharing that. And now we go to the second part of it. I'm looking at the time, 10:44. So the next round of answers should be just about 2 to 3 minutes. So I will start with Ma'am Urmila herself, Now we are going to discuss that what are the barriers that we face in engaging with patients and families for safer care. And do you have any solutions that comes off your mind? And this is getting recorded. And I'm also going to take notes to see that if there is something that we can do, we will definitely like to hear and do something about it. Over to you, Ma'am Urmila.
I think one of the primary barriers is that lack of time. Doctors are too busy. They are too caught up with their work, and even the nurses and others, either they don't have the full information, or I don't know if they are not allowed to speak so much, even if they would like to. So that is what I perceive may be the barriers. Sometimes they may not be knowledgeable enough to talk about it. So, and then I think, I don't know, excuse me, the doctors who are there, they somehow tend to think, I feel, that the patients and their attendants are ignorant. So they should not be involved. They can't be involved. So I think there is need for a side of mindset change over there, especially in this time and age when people are so aware, people are so knowledgeable. The information is available at the tip of the fingers. So what happens? People get a lot of wrong information also. So that is why I think it becomes very important to discuss with the patients, discuss with the thing, let them know that, what is it? So I'll just like to deviate a little and tell you about something like, my daughter was born, and the two doctors, the gynecologist and the pediatrician, they would come into the room, and one would say, oh, she was born little early. The other would say she was born on time. So, that made me think, what was it? And then my mother caught the nurses were feeding the baby, and the baby was turning white and blue. So then, she said that stop that feeding and all. So about 6 months later, this child was diagnosed to have profound disability, like, mental retardation and cerebral palsy, profound. And when I started talking to the doctors in another hospital, one leading hospital, they said, go back. So they said that, the very first day, what happened when the child was turning white, that was the first occurrence of a what do you call it? A seizure. So had we known on day one that this child is having a seizure, we could have done so much of early intervention. We could have done so much of care and not let those 6 months pass by. When her seizures became prominent and, we started observing that, there were some things were just not right. So that's why I'm saying that it becomes very important for the healthcare professionals to have a mindset shift and to understand that, we patients also understand that you are also humans. You do make human errors. So there may be mistakes, but it is important that we know about it so that we can also take action, not legal action. We can do what needs. Sometimes it's needed just for closure, just for acceptance that, such a thing has happened rather than keep us in the dark about what has happened.
Thank you, Madam Urmila, and I'm very sorry to hear about your daughter. We need to hear more such stories, and thank you for sharing your pain with the large audience over here. I really appreciate that. To that, I would like to go to Dr. Reshu because that's what Madam Urmila is telling, that wish the doctors were more, aligned. One doctor saying she was born early, the other one saying she was born on time. It creates confusion in the minds of the patient attendant, So, and do not treat them as though they are ignorant. So, how would you like to put that? Generally, it is not about your personal experience. This is for the larger cause. What do you think the doctors, why don't they talk enough to patients and relatives? Is it thinking they're ignorant, or they are thinking that I'm too busy, or they won't understand? What could be? Why the barrier, and what can be done?
The main important barrier, ma'am, I would say here is lack of confidence. If a doctor or a healthcare personnel is not talking to the attendants properly and giving that time, it won't, I would say that there is some lack of confidence in the treatment. If I tell you honestly, like communication is one thing which should be given very, very, very importance in that daily care system. Just giving the antibiotics, giving the treatment is not enough. You have to communicate with the patients. We have to communicate with the patient's attendant and be very frank to them. Being very frank to them does not mean that you are just telling, as Ms. Urmila also said, you have said that don't give me on ventilator. Here, I would just like to say, if I know, yes, you have a, God forbid, you should not have, but if you have a pneumonia, I know which is curable, I would definitely would like to talk to your family relatives as well as to you. Ki I'm sure if I ventilate you for 3 days, madam, you will come back and you can have a normal life. But that communication is important. And what are you showing? You have to promise them they okay. But here for Madam Gomez, as you had, it's a big bleed. There, if I say, no, don't worry, everything would be fine, that would be wrong on my part. So there we have to be very frank, we have to show them all the pros and cons of it. But if I say a pneumonia in a very elderly, where comorbid conditions are big, if there are a lot of other comorbid illness and the chances are less, then I would say these are the chances. So this is where you have to now take a call. So that part I would say is very, very important, that it cannot be an excuse that we doctors, we clinicians do not have time, so we do not communicate. It's our duty, as when we admit the patient, when we give a prescription, when we give all the instructions to the nurse, it's our duty as a primary physician there who have received the patient to communicate to the attendants there and there immediately after our investigations have come, and when we know, okay, this is the prognosis and this is what your patient is suffering for, and this is the plan what we have. So little bit, first, we should not consider any of our attendants ignorant. Everyone have a smartphone with them. They can Google search everything. As Ms. Urmila rightly said, they will come back with those Google informations which might be wrong many a times. And that perception or that clarity has to be made by that physician who is treating the patient. That's why in my first answer also I said that transparency has to be maintained and that expectations has to be known to the attendants as well. This is it. From this, I'm not a hero. I'm not a superhuman. I'll be treating your patient with the knowledge what I have, and these are the chances. Next, and I wanted to say if we are having a third round, that how we can overcome this. I have few ideas in my mind which I would like to definitely share in this session when you give me time next.
Okay, okay. We'll come back to that in a moment. So let me ask Mr. Sanjeev. I'm very sure that in your long journey, you also must have, acquired healthcare at some point of time for your relatives or, yourself. We do go as outpatient at least. So from your perspective, what do you think are the barriers? And if there are suggestions, if you'd like to dovetail into your 2-3 minutes of answer, that'll be great.
Yeah, right. People talk about time, not having time to communicate. Personally, I don't agree to that. Why I don't agree, I'll just give you one example. Years back, my father-in-law, who was 72 years old, he had a cardiac problem. He went to a local doctor. He was a well-known doctor, recognized doctor here. So some medication was prescribed. Then my father-in-law asked him when to take the medicine or how to take the medicine. And his curt reply was, go to the pharmacist, he will tell you. Now, a month later, he was in Delhi. His younger daughter was there. So he had to be hospitalized and he had to undergo the surgery. And the surgery was done by an internationally renowned surgeon. Definitely, he was much, much busier than our local consultant. After the surgery was over, not only he, every day, 2 or 3 times, he used to come and speak to him. And at the time of discharge, he gave his personal mobile number. He said, this is my number. Anytime you feel uncomfortable, you feel free to call me. And he also gave the number of another friend of him who used to stay here, that any problem you face, once you return, go to him, we'll speak about your problem. So I don't think it is only always a matter of, sometimes yes, it can be a matter of time, but mostly I think it's a question of attitude of our people. Secondly, I explained when something is not done, there are 3 principal reasons. First reason is I am not authorized. I am not authorized to communicate. So if somebody needs to be communicated and the person feels that he or she is not authorized, authority can be given. The second part is the person, it may so happen, the person feels that he or she doesn't know how to communicate. I don't know. So if the person doesn't know, then the person can be trained how to communicate, what to communicate. But my experience is mostly their attitude. I will not communicate. I will not do. So that creates the majority of the problem. I will not do. So when I say I don't want to do, either we try to motivate them or take some other action, positive action or negative action, so that they change their behavior. We need to do something to change their behavior. Because personally, I feel the third one is the most difficult one. And mostly it happens because of that. It's not because of lack of time. It's not because of lack of authority. And not always that they don't know what to talk and how to talk. I think this is my response to this question.
Thank you.
Yeah,
Thank you,
thank
Mr. Sanjeev. Thank you. I think you hit the nail on the right spot, I guess. Attitude. At the end of it, I think every single person carries an attitude to decide what they want to do and what they don't want to do. Sometime maybe they don't have enough knowledge, as Ms. Surmila told, I don't know what to do, so I rather keep quiet. So with these, finalization of saying that maybe doctors, they're very knowledgeable, they know everything, but the attitude stopped them from communicating with the patients and the relatives. Nurses also in the same boat. So let me go ask Minnie that what do you think are the barriers, and what do you experience are the barriers that stops our nurses from speaking to patients and the families? Is it that they are not allowed to speak to them, like Madam Urmila said, maybe they are not allowed, or they don't have enough knowledge? Which one is more prominent? And do you have any quick solutions to suggest? Because I may not have enough time to go across asking for suggestions. So I would like you to dovetail both into about 2-3 minutes time. Then I would hear from Karishma. She already talked some of the barriers and suggestions already, unless she has some more points. And then we again go back to the hot seat.
Okay, thank you, ma'am. So the main barrier, all the speakers have spoken communication. So is it every time the nurse is knowingly or with whatever reason she is not communicating? No. Many a times what problem I face is being in Mumbai, I do get a lot of nurses from South. So when they come, they don't know Hindi and Marathi. So a few occasions, nurses don't know language. That is why they don't communicate. Now, second is, as a nurse leader, I need to think, what is the nurse-patient ratio in my department? You give a fresh nurse, she just joined without any training, you are going to give her 7 patients and tell the nurse, oh, you need to engage the patient, you need to communicate, where she is going to get time. So as nurse leaders, we need to see that what is the nurse-patient ratio? Are we giving assignment as per acuity? Maybe all whatever 20 patients in the department, the dependability may not be the same. So that is very important. And many a hospital, what I see is nurses doing non-nursing work. You make the young nurse to do all non-nursing clerical work and you expect her to go and communicate, engage with the patient. It is going to be difficult. It all depends on the organization where you empower your nurses, you create a very good working environment. Everyone would like to. So, of course, I agree. Today's generation, there is little attitude. I am not going to communicate. That is a percentage. But if we empower, motivate, and as nurse leaders, there are solutions for every problem. So, I will give some practical points to the people who are hearing me is how do we overcome. As a nurse leader, if I don't, I know there are barriers, but if I don't give solution, how am I going to improve? So we have something training, which we call it as CCDC. CCDC is communicating care, delivering care at the bedside, which is a 3 days program where the nurses have given scenarios. We teach the patient how to enter the room, how to handle a difficult patient. So 2 things are taught in that, which is edit and lead. So how to communicate? You have to acknowledge, you have to introduce yourself, and what is the duration of your talking, and explain, and finally end to say thank you. So edit and lead. In lead, we talk about listening, empathize, apologize, and provide solution. So this is in CCDC. So it is mandatory for every new nurse to undergo this 3 days training program. Then next my barrier is nurses doesn't know language. So we have something known as Art of Hindi. So this is a book we give to every nurse. They all undergo training, Hindi training. So once upon a time, I have learned Arabic when I went, which is 25 years before. I had undergone Arabic training when I was in Gulf. So now we are teaching our nurses how to talk in Hindi. And the third very important is how to communicate during procedure. Now, in the first question, I said, yeah, you can communicate while doing, while assessing, while doing initial assessment. So we call, that is a recent training module which is started by Fortis. We call it as Spandan. The meaning of it is Aapki Dil, that is a tagline, Aapki Dil Ki Baat Jano. So Spandan meaning it's a Sanskrit pearl. So it is 1-day training program, which is a procedural communication. During procedure, how nurse need to communicate. So we have created procedural communication for initial assessment, medication administration, and fall. So I believe, as nurse leaders, we know there are barriers, but to come across barriers, we need to have solution to support our nurses, and coming together, doctors need to support the nurses to talk. When the doctors come for rounds, ask the nurses about the patient, and nurse proactively, if she has the knowledge and skills, she'll be able to, communicate and engage the patient. Another biggest problem is nowadays nurses pass out the very poor skills on procedure and knowledge. So these are some of the training we can develop in your own organization and come across. So I believe if we come together as a team, as Madam, we can support our patient, and whatever issues Madam Urmila told, we will be able to resolve our patient issues.
Thank you, Minnie. I think barriers and solutions you gave, that's great. I think we should have a chat separately to see that how your solutions can help more number of nurses across the country, because CCDC and Spandan, all this, I think what you touched upon is that communication should be broken down into critical conversations, or we call it crucial conversations. You don't want to talk about movies to the patient. It'll be nice if you know everything else, you can chat up the patient by asking which movie you like, but you need to reach there. Before that, there are some critical and crucial conversations which nurses must master, and that can be done through trainings. And I hope that, we can do something to take this out for students and nurses through Annie. That's what I'm hoping. So you already have a solution. We'll talk about it later. So that's great. Thank you so much for that. And it's very, very important that one thing that I just wanted to emphasize was that, because Dr. Ashish and Dr. Reshu is also here, so I'm getting a little greedy to say that. One of the things that I have seen is that our nurses, whether it is here or in outside or anywhere, they don't want to look stupid in front of a consultant with whom they're working. If you give them a chance to talk first about the patient, I can guarantee that your nurses will improve much faster than me and Minnie talking for hours together. I can tell you, it's actually a magic sitting in your hand. Give them a chance. I tried this when I was in Fortis. It gave fantastic result. But who got tired? My consultant. He said, oh, it takes me a little bit more time to do the rounds. Otherwise, I can go through and just tell my team, okay, tell me what's the thing, and, give orders and out. But when I asked the nurse first to tell me what's the patient's update, and I had a great team of nurses when I was the ICU in charge, I developed them only because of my consultant support. But they don't want to look stupid in front of the consultant. But me, I'm like their mother, always after them. So it's okay. Once in a while, I make a mistake, no big deal, So I really hope that this is a solution which is sitting, but it can only happen within the organization if the top management and the HODs of the various departments, especially critical care, will support in this practice. And if you can practice this, I can guarantee results. If you don't get it, do anything to me. Now we move on to Karishma. You already talked about the barriers and the solutions. Do you have any other solutions in mind in this today's day and time, because you are from that younger side? What do you think that can be done by anyone sitting here?
Thank you, ma'am. As you have rightly said about consultant involvement, that was my point, ma'am. So there is something called consultant intervention initiative. So as you rightly said, we do not like to be stupid in front of consultant. When they ask something, we do not want to miss anything. So physical handover, when ma'am Minnie said that, although we say bedside handover, so many times it remains in the papers, in the documentation. So which is a very crucial point of engaging patients. What happened in the last shift, what we are doing with you, those things remain unattended. So the consultant intervention initiative, which when consultant comes for if it becomes a part of high-risk initiative like medication administration process, like critical lab alert value reporting. So if engagement of patient family process becomes a part of high-risk initiative, which is I believe and I know that this patient family education is a part of accreditation bodies in very importantly, like they always audit PF has been done or not. But if engagement of patient family taken in that serious step, then I think no nurse will miss to do this, because as Sanjeev sir has mentioned, time is not a matter. How much time we take to talk. While doing many procedures, we can talk abundantly with the patients. But when we say that, why didn't you introduce today to the patient? Then, oh, I missed. But did you check the vitals? Yes, I checked the vitals. So there is always a, the nurse's attitude towards this part of engaging the patient and family, that they are not understanding their importance, how much potential or how much capability a nurse has in the healthcare. As ma'am rightly said, that patient being in the center, then we all are around. If we do not engage them, then it is not going to benefit the patients. And if we make the nurses understand that you are that a journey of satisfying the patients, you can leave that footprint in the patient's life for their entire life by only engaging the patient family. We do not miss any point. Many times patient became critically ill, it is a medical emergency, and patient shifted to ICU, and consultant asked, okay, what was happened with the patients? The nurse is not able to say many times what happened because of not engaging them in all their care, what happened. But again, one more point, the nurse who desire to grow in their professions, young nurse who desire to steps ahead in their profession, they always think, okay, these are my ways forward to go ahead. And if I do not know, if I do not impress the consultant, or if I do not become the best, then I cannot reach there. So see, those kind of nurse who has a desire to go ahead, they do follow. But the few nurse, they just left it unattended. They do not feel that they recognize that it is an underestimated need for the patients and for herself too. As I earlier also said, it is a win-win game. If we make them understand that engagement of patient family is such important for you and for the patient, and finally for the organizational goal, then I think we can go ahead with more succeed way. That's
Thank
all
you.
I want to say, ma'am. Thank you.
Karishma, so you said the more organizational way. So let me ask Mr. Ashish, Dr. Ashish Malakar, that in all this game, all this focus on patient and family, there are barriers. We understand that we are hard pressed, attitude is a problem. So do you think any other barriers are there, especially for the top management, to make this thing a reality? I am not asking you as an individual. I'm asking you as a, CEO representative in the country of the healthcare delivery system, that what is it that, we can find some solutions. We have another 6 minutes. I have one final question to ask all of you. So, sir, your 2 minutes answer.
I have heard from Dr. Rishu, she said about confidence. Mr. Kakoti has said about attitude. I think, whatever you call, we don't have time and all these things we have discussed. But we should not forget this patient, they paid us. They paid us for this, and we should, as an institution, we should bring it to the fore. In fact, we should bring it to our consultants, all our healthcare members, that you need to give them time. This is why they came to you. They did not come here to just for having some fun. I mean, communication, when you talked about, is the tool where as the top of the organization we can enforce upon. And when you talk about attitude, I think it is all about humility. We should understand, being in healthcare, you have to be different, else you should not be in healthcare. Just for showcasing a knowledge and how knowledgeable you are. That you could have done in many other spheres. And if you don't have that tender, loving care towards your patients, you should not be in healthcare in the first instance. And I'm very critical about it, and I take very strong note. In fact, as an institution, we need to make a program in which, this kind of education needs to also be given to the doctors, as well as the nurses. You talked about, nurses feeling stupid, I would rather call that consultant who behaves in such, fashion would rather be a stupid person than if he behaves because the nurses, I have learned a lot myself. I was a clinician. In fact, I started my career learning the simple thing of, how to draw a syringe from the nurses. So that's, I have nothing to be ashamed about, I'm very proud of that, and I have always felt, and I have reflected that in my career, that, by setting up various nursing colleges, because I feel the backbone of healthcare is the nurses. Coming back, when Mrs. Borua, she has said about a very important thing. I think shared decision-making is one aspect we need to do. Patients and families must be involved in all aspects of care. They have to have a say in making of decisions about treatment plans. And they have to have a thorough understanding of the diagnosis and the risk and benefits of all options we need to give them, as well as patients and families must be encouraged to actively participate in the care decisions. As we as healthcare providers, we share information about different treatment options and risks and the benefits, but then all this needs to be collaborated with the patient and making informed choices. I think education and empowerment is also very important here. Patients and families must be provided with a clear and understandable information that their conditions, treatment plans, medication, and potential risk. And this empowers them to actively engage in their own care and make informed decisions. I think we must provide the patient and their families with educational materials also, like brochures, like videos that explain the importance of their role in ensuring the safety. Then we have to offer information on the topics, such as hand hygiene, medication safety, infection control, educate their families, on their health conditions. I think involvement is so important in this aspect. When you talk about it, don't have time, I think then it should not come into healthcare. Involvement is the most important aspect. We encourage the patient and their families to actively participate in their care by asking questions, expressing concerns, and sharing the medical history or allergies. This orientation, conducting a comprehensive orientation of patients. And very important, if you say we don't have time, being an institution, we should put forth, even if we don't have anything, a patient safety ambassador, a SPOC. We should designate a patient safety ambassador to advocate within the hospital staff who can serve as a point of contact for the patient and their families. And this person can address their concerns, provide information, and ensure the safety needs that are met. And above all, the feedback mechanism I'd like to emphasize, they're there. But, what kind of feedback feedback is for our own improvement. We should know from the patients, how do we improve ourselves? I think that's in the beginning of you set the tone of this thing by stating that, it comes from the patient, and for the patient we need to do. So, where patients and their families, we can share their experiences and suggestions for improving the safety of the hospital as well as the patient. They will be benefited from that, because that will, and ultimately when you talk about being a CEO, you told about the PN and all. My business is the precursor of my all hard work, is that the patient should feel this organization to be a safe place. And that's the reason, I think we need to support this whole program. I think time is very short here today, but I think you have taken a great initiative. We can take it forward. And if given an opportunity, I have much more to speak about in other forums. Thank you so much.
Thank you, Dr. Ashish. I think your willingness to give more is always welcome. We will definitely be coming back to you, because in the next panel, there is much more going to be discussed from non-healthcare, professionals from patient safety, and there are experts talking about how to engage patients and family more, with actions, what they are actually doing. So before, it's already 11:15, so I don't have time to extend this track. I would like to say thank you so much to each and everyone for such an enriching discussion. And I know we can talk for maybe 5-6 hours. If time permits, we will have so much more to do. But I can only summarize by saying that all of us agreed that we must engage patients and families. We must listen to them, not hear them, listen to them to understand how we can engage them, what are their doubts. And we don't have to decide based on their caste, creed, religion, their money matters, how much they can pay. They have a right. It is their body, it is their treatment. So we need to explain to each and everyone. And then, of course, there is a whole lot of educational support needs to be given through either videos or pamphlets or everything. And in the middle of it, there is a lot of training requirement that is required, agreeing that the quality and safety are two sides of the same coin. Mr. Sanjeev, we totally agree. So there is no route or destination to quality without safety. And both of them there is no destination. It is always a journey that we keep on improving. So for that, it's very important to admit that there is something lacking. Then only we can improve. But if we are like a cat drinking the milk, because they close their eyes and drink the milk. They think nobody is watching me. So that should not be the attitude, you know. Ma'am Urmila, thank you so much for setting the tone and sharing your experience. We hope to come back to all of you in some form or the other in some future webinars so we can discuss more on this. And definitely, as an association, we will be thinking very seriously what more can we do to spread this awareness of engaging patients and families. Thank you so much to all of you, and have a good day and stay blessed in your wherever you are, and let's continue to contribute to patient safety. Thank you, Dr. Ashish. Thank you, Mr. Sanjeev. Thanks, Minnie.
Thank you.
Thanks, Karishma. Thank you, Dr. Reshu. And thanks a ton, Ms. Urmila Barua, for coming here and telling us what you exactly need. Thank you so much.
Thank you.
Panel,
Thank you.
and I will hand over to the anchor to take us to the next session. Thank you.
Thank you, Thankam ma'am, and all the panelists. Now, we have come to the end of the panel discussion, and it was truly enlightening to hear what each of the panel members had to say on the given subject. I'm sure the participants' minds are active, thinking about how to translate the insights into action in their organizations. Now, I take your leave and I request Ms. Parveen Akhtar Chaudhary to take over. Thank you.